Our next presentation is a somber milestone. COVID-19 claims more than 1 million Americans. More than 1 million U.S. residents have died from COVID-19 since the pandemic began, and it's become the third leading cause of death in a little over 2 years. In this session, we'll examine data, disparities, and the sociological effects of this grief and ways to move forward. Our speakers from this panel include Farida Ahmad from the Centers for Disease Control and Prevention. And Ms. Ahmad is here with us. And then online, we have Dr. Ye-Hung Chen from the University of California and Dr. Emily Smith Greenaway from the University of Southern California. Ms. Ahmad, you have the floor.
Good afternoon. Today I'll be talking about trends in mortality and life expectancy using data from the National Vital Statistics System. So I'll start off with a little bit of background about NVSS. So the National Center for Health Statistics collects, codes, and disseminates the nation's official vital statistics, including births, deaths, and fetal deaths. Mortality data are based on information from all death certificates filed in the states, DC, and territories. And the data that we released, you can kind of think of it in two terms. There's the final annual data, which are after all of the updates from states are received and processed, and we fully review those for completeness and quality, and that's what our official annual reports are based on. And then there's also provisional data, which is based on a snapshot of the data that we've received as of a specific cutoff date. And so currently the data for 2021 and 2022 are provisional, and a lot of the data that I'll be talking about are the provisional data from these most recent 2 years. So I'll dive into the data. So first, we'll look at overall age-adjusted mortality rate in the United States. And so I've presented the numbers for the last 5 years, but for 2021, the rate was 858.5 deaths per 100,000 population. In 2021, the death rate had increased by 0.7% from the rate in 2020. Overall death rates in 2021 were highest among non-Hispanic, American Indian and Alaska Native persons, and non-Hispanic Black persons. COVID-19 was the third leading cause of death, and the death rate for COVID-19 was highest among non-Hispanic, Native Hawaiian, and other Pacific Islanders. So the top 3 causes of death in 2021 were the same as in 2020, with heart disease, cancer, and COVID-19. In 2021, there were 60,000 more deaths due to COVID-19 than in the prior year. Other causes of death also saw increases. So we saw increases in heart disease, unintentional injury, hypertension, diabetes, and chronic liver disease and cirrhosis. There were increases in others, but these are the ones that I highlighted. And we also saw some decreases in chronic lower respiratory disease and influenza and pneumonia. So the changes in death rate and causes of death also led to declines in, or manifested in declines in life expectancy in 2021, as seen in a recent provisional report that was just published in August. So life expectancy at birth declined by 0.8 years. Half of that decline was attributed to COVID-19, and additionally, sharp increases in drug overdose deaths also contributed to the observed decreases in life expectancy. And one thing I wanted to mention, maybe I can go back real quick. As you see that there were increases in unintentional injury, and that category includes drug overdose. So we saw the increase in drug overdose deaths reflected in the leading causes of death, and then also in the declines in life expectancy. Life expectancy varies by race and ethnicity. Changes in life expectancy were also seen varying by race and ethnicity. From 2019 to 2021, non-Hispanic American Indian and Alaska Natives saw the greatest decrease in life expectancy, with a loss of 6.6 years. Hispanic persons lost 4.2 years, and non-Hispanic Black persons lost 4 years. Another way to look at disparities in mortality is to examine deaths by race and age, and so the slide looks at the, sorry, one second. This looks at the disparities from 2020 to present. So this visualization shows the percent differences in the percent of COVID deaths compared with the population distribution of that same racial ethnic group. We see the highest burden among younger ages for Hispanic, Black, and Alaska Native populations, whereas white and Asian populations have experienced lower burden of deaths compared to their population distribution. And this is part of a dashboard that we have on our COVID-19 website that examines health disparities, looking at population distribution, age, et cetera. And then one last graphic that I want to show you on this last slide is looking at excess deaths by race and Hispanic origin. So whereas the previous slide looked at COVID-19 deaths, this is looking broader at overall deaths. And what this shows is the percent change in weekly number of deaths in 2022 compared with the average number for prior years, so 2015 to 2019. So we're looking at excess deaths, and excess deaths are a measure of how many deaths we're seeing compared with what we would expect to see in a typical year. So by looking at excess death data by week, we can see which groups are being most affected over time throughout the year. Across the board, we're seeing more deaths than expected, and this is more pronounced for certain groups than others. Please note that data for more recent weeks are incomplete and should be interpreted with caution. And that's a caveat that I put on all provisional data, that it's subject to change as we get more information. Thank you.
Thank you very much, Ms. Ahmad. Our next presentation is Dr. Yehung Chen from the University of California. Dr. Chen, your slides are up and you have the floor.
Thank you. So as we reflect on this milestone of 1 million individuals lost to COVID, I think there are, as you all know, many stories that can be told and have been told. I think an important part of the story is that there have been many young individuals who have lost their lives to COVID. Next slide, please. So around a quarter of COVID deaths have occurred among individuals under the age of 65, representing roughly 250,000 individuals. Huge implications for the economy, certainly those left behind. And I think this group of individuals represents a very important opportunity for intervention. Next slide, please. Part of the story, I think, about younger individuals is that in many cases they work. And as many of you know, there was concern early and throughout the pandemic about so-called essential workers, particularly because shelter-in-place orders in many cases specifically exempted those workers. So the logic was that, well, maybe if we say that these individuals are excluded from these protections, they might actually have increased risks. And in fact, as you all know, there have been numerous reports of workplace outbreaks. There have also been reports of inadequate workplace protections, inadequate PPE, or unclear safety guidelines. Next slide, please. But the epidemiological data on this were lacking, particularly early on. And this is partly, I think, largely because occupation is not systematically recorded in surveillance oftentimes. Next slide, please. This led us to do a study of occupation and COVID mortality using mortality data from the state of California. So occupation is recorded in death certificates, so this lent itself to this sort of analysis. Next slide. So we report on COVID deaths. We also report on excess deaths. I'll focus in my talk today about COVID deaths, but also show some slides on excess deaths. We looked at excess deaths in large part because we were very concerned about underreporting of COVID deaths. Next slide. This basically illustrates the idea of what the prior speaker was talking about of what excess mortality is. So here, the red line is observed deaths in 2020 among working age individuals. The blue line represents the expected number of deaths had the pandemic not occurred. Slide. There are a lot of numbers here. I will draw your attention first to the total number of COVID deaths among working age individuals, around 6,000 COVID deaths. You can see their distribution here. So large numbers occurring among unemployed individuals or individuals in non-essential sectors, but also large numbers occurring in certain sectors, including facilities and transportation, for example. Those numbers, those distributions are, of course, dependent on the number of people in those groups. So we might look instead at per capita numbers, per capita excess, that's that third numeric column. And what we see is very high risk in certain essential sectors, facilities, food and agriculture, manufacturing, and also transportation and logistics. One of the things that you might notice here, which we have found interesting, is that the excess mortality among the health and emergency sector is relatively low, and we think that is largely due to differences in workplace protections. Next slide. This shows a measure of excess mortality. This is a relative measure observed divided by expected deaths. Over time, these vertical lines separate different quarters of the year. So each quarter is 3 months. What I mainly want to draw attention to is that you see excess mortality rising very quickly in certain essential sectors, including that first quarter when we know the state was sheltering in place. If you look at food and agriculture, for example, we see a very rapid increase in excess mortality. You don't see that, for example, among non-essential workers. Next slide. This is analysis by specific occupations. We were able to calculate these measures for various specific occupations, and this list here is ranked by our relative measure of excess mortality. Not all the occupations are shown, but some of the occupations on the top include garment workers, cooks, agricultural workers, and so forth. Next slide. So there were a lot of questions. Question that I heard most often when we released that study was, well, what about the rest of the country? That was California data. When I think about that question, what I ask myself is, are there differences in workplace protections across different parts of the country? And I don't believe so. But fortunately, we were able to get national data and do an analysis on national data. So next slide. So this table shows, this is now COVID mortality, per capita COVID mortality. I'll draw your attention to the standardized column. That's a standardized, age standardized COVID mortality rate for different occupational groups. So very, very similar findings to what we see in California: accommodation, food services, transportation, so forth. Next slide. This is showing just a little snippet of our analysis at the national level for specific occupations, and very, very similar specific occupations coming up as we saw for the California analysis. Next slide. And finally, another question one might ask is, well, what about the vaccine era? Right, so our first study came out during a time when the country was trying to figure out vaccine prioritization, and fortunately, there was prioritization for essential workers in many cases. and you might wonder what these numbers look like in the vaccine era. Next slide. So this shows excess mortality over time in various sectors. I know it's a little hard to read. The blue line in each of these panels is exactly the same. The blue line in all the panels is the workers in the non-essential sectors. And that's just provided as a reference to facilitate comparison between the specific sector of interest and non-essential sector. The vertical lines denote various periods of the pandemic. These data are now through late 2021. And these lines primarily separate out the surge and pre-surge periods. The last two periods represent a vaccine era. Okay, so what's interesting is that you do see that in many cases there are still disparities between in COVID mortality between workers in various essential sectors and workers in non-essential sectors. So if you look at agricultural workers, for example, on the top left, you can see particularly in that fourth phase, which is vaccine era corresponding to the Delta surge, you can see a noticeable disparity. What's interesting, however, is the center panel healthcare sector. You see virtually no differentiation during the vaccine era between healthcare workers and workers in non-essential sectors, which I find very interesting. One of the things that we are concerned about is workers in the emergency sector have emerged as a group that has very high risk, and we think that particularly during the vaccine era, and we think that could be due to low vaccine uptake in that group. Next slide. Finally, I wanted to show this visualization. So we did an analysis showing additional stratification by high or low vaccine uptake in the region. And the blue lines here are showing low vaccine uptake regions, and the red ones are showing high vaccine uptake region. And this is stratified by occupational sector. And you can see that regardless of occupational sector, the risks are higher in the low uptake settings. Next slide. I'll talk now about some of our recommendations. So I mentioned our first paper coming out during that time of discussion about vaccine prioritization, and certainly we support it and recommend prioritization for essential workers. Vaccine uptake, as you all know, remains an issue in certain sectors. I mentioned the emergency sector, for example, and certainly in certain communities, as you know. Next slide. Other recommendations, I think on a data note, I think, I did want to put out that I think it's important to consider extending reporting of occupation to other, in public health surveillance in general. Certainly we need an investment in healthy workplaces that could mean stuff like ventilation, that could mean PPE, guidelines, and certainly structural policies such as sick leave we view as being very important. I also wanted to mention our research group is very interested in this idea of recovery, what happens to hard-hit communities as we move forward, and many, many concerns about essential workers and their families as we move forward. I know Dr. Smith-Greenaway will be talking about some of that. Thank you.
Thank you, Dr. Chen. Our next presentation is by Dr. Emily Smith-Greenaway from the University of Southern California. Dr. Smith-Greenaway, your slides are up. You have the floor.
Great. Thank you so much for the chance to be here with you today, even if remotely so. Today, I'll be presenting work on behalf of a large collaborative team who you see acknowledged here. And I'll be shifting the focus a little bit to talk about COVID-19 mortality from the perspective of those who have survived it. I'll give you a sense of both the levels of COVID-19 bereavement in the U.S. and also the population health consequences of this immense amount of grief that our country has endured. Next slide, please. So very early on in the pandemic, we saw this, quick concerted effort to emphasize that COVID-19 mortality was, concentrated only among older adults. Of course, this was problematic, not only that it was verifiably false, and in that it, really had a way of trying to kind of devalue older adults' lives. But for my colleagues and I, it also symbolized this tendency to think about aggregate mortality trends and to think about, mortality risk from an individual vantage point. But my colleagues and I who study bereavement and kinship and population health, recognize that for each premature death, there's also, a concentric circle of people in that person's social network and their kinship network that is deeply affected by these deaths. And so next slide, please. Very early on in the pandemic, what we wanted to do is try to, rescale the COVID-19 mortality crisis in terms of the amount of bereavement that it would exact on our country. Now, we started this work in the spring of 2020, and we were well aware of the fact that we were, entering what we expected to be a multi-month or multi-year public health crisis. And so we didn't want to just answer this question of, how many have already been bereaved by COVID-19 mortality, but instead we wanted to create a tool that would allow us to track with the rising death toll how many on average are affected by COVID-19 deaths. So we wanted to create an indicator that would allow us to really track in lockstep fashion with the dashboards, emphasizing how many lives have been lost, how many were intimately affected by these deaths. Next slide, please. And so what we do is we make use of demographic microsimulations to do this. So my colleague, Ashton Bergery, who has led much of this work, him and his colleagues who are also involved in this project had already laid the groundwork for us prior to COVID. So they had been doing a lot of work using demographic microsimulations to understand family change in the US. And so with these data, which basically use formal mathematical demography to map the size and structure of family relationships, allow us to really track, to match these data with COVID-19 mortality data to demonstrate how COVID mortality reverberates across kinship networks. And so the microsimulations that we use closely correspond with survey data on US families, but it allows us to basically simulate, what happens to family structures with COVID-19 deaths. And so, next slide, please. And so our data allow us to attend specifically to the bereavement of close relatives. So our data only allow us to speak to grandparental, parental, siblings, spouses, and children. And so what you're looking at here is our estimates of the age distribution of COVID-19 bereaved individuals. This is our bereavement multiplier demonstrated across different age groups. So the area under this curve is the sum of this multiplier. So we estimate that on average for each COVID-19 death, about 9 people are left having lost a close relative. Again, a grandparent, parent, a sibling, a spouse, or a child. So this age distribution that you're looking at, very quickly demonstrates that COVID mortality is not only affecting older adults. We see this bimodal distribution where, much of the bereavement burden is actually experienced by younger people because they are losing parents and grandparents to COVID-19. Next slide, please. So our estimates also allow us to give a sense of the relationally specific losses, right? Like who is dying in these kinship structures, who is bearing the burden of these deaths. And so we do see, because of the steep age gradient in COVID-19 mortality, much of the loss is the death of grandparents. We estimate that on average for each COVID-19 death, about 4 people are left grieving a grandparent, 2 left grieving a parent, 2 having lost a sibling. For each 2 COVID deaths, we estimate someone loses a spouse, and for about every 10 COVID deaths, someone loses a child. And of course, these relational losses follow really different age patterns as we would expect. Next slide, please. So because our simulation showed remarkable stability in these estimates when we assumed different epidemiological trajectories and made different assumptions in our data, what this tool allows us to do is to track with the rising death toll the corresponding rise in bereavement as a result of COVID-19. So as of this month, we estimate that about 9.4 million people in the U.S. have experienced a close relative die as a result of COVID-19. Next slide. We can also use this model to track the waves of bereavement that have corresponded with the spikes in mortality. We see again how many specific relational losses there have been. One estimate that's of high interest to many individuals is how many children have lost parents. So even though we do see, COVID-19 mortality following a steep age gradient, the sheer scale of COVID deaths in our country has left, we estimate, about 80,000 children under the age of 18 having lost a parent. So this is a significant rise in how many children in a typical year experience the premature death of a parent. Next slide. So what does this mean, right? What do we take away from this? Well, it's very concerning from a population health perspective that this mortality event is kind of leaving this residue on our population, if you will, because we know with pre-pandemic data that losing a relative is highly consequential for survivors' well-being. We know family bereavement has social, educational, employment, relational implications. We know individuals who have recently experienced a family loss have worse mental health outcomes on average. Some forms of bereavement, particularly the death of a spouse, even comes with an elevated risk in all-cause mortality in the coming months. So this is all quite concerning that we see this remarkable rise in bereavement in our country. Next slide. But there's reason to be even more pessimistic than that, right? There's reason to think that COVID-19 deaths in particular may be even more difficult for people to grieve, right? There's this sense among sociologists that COVID-19 deaths are, quote unquote, bad deaths. They happen in isolation. They're painful. They're sudden. They're, really concerning for those who witness their relatives experience these deaths. Of course, the COVID-19 pandemic also disrupted society to such an extent that, funerals were postponed. There was so many social disruptions. And so all of this leads us to think that COVID-19 bereavement may have even more pernicious consequences. Next slide. So we wanted to try to empirically estimate this, right? This has been kind of a narrative thrown around, but with no empirical proof. And so we ask, is COVID bereavement distinctly challenging for those who have endured it? Is there some sort of differential impact? Next slide. Of course, this is really difficult to do. And so what we do is we kind of serendipitously make use of the fact that this SHARE data, which is a multi-country survey of older adults, their data collection was disrupted by the COVID-19 pandemic. And so what we're able to do is take data on older adults that had just been collected immediately prior to the pandemic, and we compare it to data that was collected in the first 3 months of the pandemic. And so what this allows us to do is to compare specifically COVID-19 widows and widowers to pre-pandemic widows and widowers. Next slide, please. And so here what we're doing is we're just looking at self-reported outcomes of mental health, how older adults are doing in terms of their depression and their loneliness and their sleeping patterns. And again, what this allows us to do is to compare COVID widows and widowers to those who were widowed or immediately prior to the pandemic. Next slide. And so we very carefully attend to temporal effects here. We're ensuring that we're comparing apples to apples, if you will. Here, I'll just share with you results where we're focusing on individuals who had experienced a spouse die precisely 3 months prior to the pandemic. Now, the COVID bereaved spouses that we're focusing on also had a spouse die within the prior 12 weeks. And so this is kind of a perfect comparison of these two groups so that we can answer this question of whether or not COVID bereavement is distinctly consequential for those who have experienced it. Next slide. So I'll walk you through these results really quickly to give you a sense of what we're finding in this work. Here you're looking at pre-pandemic estimates comparing differences between those who are widowed and those who had not recently been widowed. So as we would expect based on a vast literature, we see, pre-pandemic, immediately prior to the pandemic, those who had just experienced a spouse die are much more likely to report depression. They're much more likely to report loneliness. This is exactly what the literature would suggest. Next slide. And then we have data on, the vast majority of our respondents during COVID who had not recently lost a spouse. And so what we actually see is kind of surprising, but this has been documented in other data. Those who had not recently lost a spouse, actually older adults, depression declined. We saw some kind of improvements in mental health or comparable estimates. But what this allows us to do, next slide, is to have a counterfactual, to have a sense of what we would expect the widows and widowers to look like during the pandemic. Next slide. But what our models confirm is actually those who were widowed during the pandemic are doing even worse relative to what we would expect with data based on pre-pandemic widows. So we see that rates of depression among the recently widowed during COVID are even higher than we would expect, as are rates of loneliness. So this gives us some sense that, COVID bereavement is not only replicating what we see in past bereavement work, but it's even more consequential for those who have experienced it. Next slide. And so what do we make of these results? Well, first, this work, emphasizes that millions of people have experienced COVID-19 bereavement, and this comes with very real population health consequences for survivors. So the scale of this mortality shock is even greater than just the lives lost, because our work is demonstrating that it affects, such a large number of survivors. Very concerning is we're finding, initial evidence to suggest that COVID bereavement is distinctly consequential, which really demonstrates the need to attend to COVID bereavement as potentially having secondary health consequences. So our recommendations, of course, are, concerted national efforts to reduce COVID-19 mortality further so that we, don't have these downstream population health implications. And of course, our work emphasizes the need to invest further in research infrastructure funding to really understand bereavement. In some regards, COVID-19 bereavement is a bit of a drop in the bucket. We have other, mortality events happening in our country, like the opioid crisis that was discussed earlier, persistent racial inequalities. And in some ways, COVID bereavement is just among the many other sources of bereavement that really need more attention in terms of both research and policy. Next slide. So thank you very much. Again, acknowledging collaborators and funding, and I'm looking forward to your comments and questions.
Thank you, Dr. Smith-Greenway, and thank all of the members of the panel. Are there any questions or comments either from our members in the room or on the line? Yeah, I just reflecting as we've heard these three presentations on where we are today, in my clinical world, as well as thinking about those of us here in our committee meeting, we've had a tremendous storm that we have weathered to this point. And I think about the number of our healthcare workers that we have lost, both to the pandemic itself, as well as those who have stepped away from their careers in healthcare. It's affected, obviously, lots of other industries also. But I think the effects of bereavement clearly are beyond just families and affecting many of us in our society. And at least, my uneducated view on the topic is that probably plays into some degree in our degree of divisiveness that we see. John Douglas, I see you have your hand up.
Yeah, thank you, Bob. That was a very profound initial comment. This was a great panel. I had two questions. One, given Dr. Smith-Greenway's emphasis on age and bereavement, it was a question for Dr. Ahmad. Were you able, or have you thus far looked at reduction in life expectancy by age group? I mean, I'm assuming that Well, I'm not sure what to assume. In other words, we had the greatest mortality in older people, but they had the least life left to expect. Do we have any, and you showed us very nicely the race ethnicity variations. Have you looked at it by age group?
Yeah. Yes. The paper that I alluded to that was released in August, I do believe it has a little bit more breakdown by age, but I do know, I can say for sure that the data from 2020 I think that was published in July, that has extended life tables by age. So if you contact me after, or offline, I can probably I can get you the links to those papers and the life tables.
Okay, thank you. And then for Dr. Smith-Greenway, what are your hunches about the worst bereavement that you've observed during COVID? That was in 2020, I think you said. And do you think most of that was due to the profound isolation people were experiencing anyway that was just accentuated when you lost someone? Or
Yeah, thanks for that question. You're right that our work looking at the consequences of bereavement is concentrated among this initial period. And certainly, I think one question that we're interested in asking further, and we haven't done this yet, but this work is in progress, is to ask if there's within pandemic differences, which I think is what you're getting at, right? And you can imagine in some regards, the initial phase was so consequential for those who had lost a spouse. We were so isolated. We were all separated. There was really like the social safety net had kind of just fallen out. But then you can imagine later in the pandemic, some, and just anecdotally speaking, people who lost relatives who had decided not to get vaccinated, right? And the grief that produces, the guilt that has. So I think this is an open empirical question that we're very interested in answering. Is there within pandemic effects that play out given the really different circumstances of losing a relative in spring 2020 versus, January 2022.
Mm-hmm. Thank you very much.
There's a question from Jeff Dushin, please.
Thank you for these amazing presentations. These are so important to help inform our understanding of the severity and scope of this outbreak on our community. Two questions. One is, will we continue to be able to monitor the types of data that you've presented to us as the outbreak evolves? And two, are the data that you're sharing with us being used, in your opinion, to help inform policies that will address the disparities and the high levels of disproportionate mortality that we're seeing across particularly occupational sectors? I mean, clearly we need to be collecting information about occupation as part of our routine surveillance, but we have data now that is very stark and shows that there are very glaring disparities. And I'm just wondering, I mean, for NVAC, we can sort of take this information and use it in the context of recommendations around perhaps differential policies for occupations, or the need to, emphasize the importance of vaccination for certain types of workers. And are we engaging, appropriately the stakeholders that can make that happen? Is the business sector, the manufacturing sector, and so on, are they aware of these data? Are they engaged? What can we do to make sure that these data are actually translated into action so that we don't continue to see these types of graphs and charts? Thank you so much.
Thank you. It sounded like that question was meant for all of us, but I'll tackle the occupation-related question. It's a really good question. We as a group we're fundamentally guided by an interest in action, and we hope that people see our data and act on it. And we have seen signs of that. We know, for example, that our studies have been cited in court cases. Our study was cited in the vaccine mandate case, for example, that went to the Supreme Court. Communication is obviously part of that, and you touched on that. And to the extent that we as scientists can can be available to communicate our results, I think that is really important, and to advocate for action. The data element is really important, and I don't, to my awareness, many states do not collect occupation in case surveillance. I know Hawaii does. I don't know off the top of my head what other states do that. But I think having that sort of data would be really important. Do others want to comment on some of the other questions, the other elements of the question?
I can add a little bit regarding data on occupation data in relation to death certificate data. We do the Division of Vital Statistics. We're working with some colleagues at NIOSH to standardize the coding of occupation data that we have existing from death certificates. I'm not sure when the data will be published, but I do know that work is underway, and it is a priority to get that information out, not just for prior years, but also going forward. So I think it's really important, and it is something that we're actively working on.
Rob Schechter.
I'd like to echo the thanks for the presentations. I was wondering, looking at the excess cardiac mortality, if there's any thought about the role of vaccination in preventing some of the excess mortality that might be chronic sequelae of COVID. That might be really hard to tease apart from access and deferred primary care and other factors, but I'm just wondering if there's any clues to long COVID or long-term sequelae of COVID in the excess mortality data.
Not that we know of. One, you mentioned vaccinations, and so that's one thing I can certainly say is not on the death certificate. So the data that we're using, the death data that we use, we don't have any vaccination information. In terms of long COVID, that is something that we're looking at and hope to have. That's something that we're trying to analyze and see if we can glean that data from death certificates on long COVID, but we don't have a standardized way to do that yet.
Any other questions or comments online? And if not, I want to thank the members of this panel. Somber topic, but we appreciate all of your efforts in these areas as we continue to move forward through where we still are in our COVID-19 pandemic. We've now come to our time for our federal agency and liaison representative updates. We're going to start with our federal agency updates at this time, and we'll start with AHRQ is Robert Johnson. You want to do your presentation?
So Robert Johnson, BARDA. So just a couple of brief comments. Some I think we've talked about today. So BARDA continues to coordinate and collaborate with our industry partners as well as across the federal agencies and our state and local partners around the COVID-19 response. So over the last 3 months, we've seen the rollout of the pediatric vaccine for under 5 and 6. We've had the licensure of the Novavax recombinant protein for primary series, and most recently the bivalent rollout. So a lot of work in that area by a large number of people across the federal government, and again, all of our many partners in industry as well as at the state and local level. We've also, over the last 3 months, done several actions which have been discussed briefly, so I won't go into detail, to increase the supply of Jynneos, originally developed in partnership with BARDA, others at HHS with Bavarian Nordic for a smallpox vaccine, fortuitous for a monkeypox indication as well, so working to increase that supply. And finally, just touch on one of the products that we partner to work on is the filovirus vaccines, partnering with Merck for licensure of their Ebola Zaire vaccine, as well as working with others on Sudan and Marburg, and just point out the 3 outbreaks over the last 3 months. That's on everybody's radar. It's something we continue to work on with our partners. Thank you.
All right, thank you, especially seeing that Ebola pop up on the news feed this morning. Yeah. Next for CDC, Ram Kapaka. All right, we'll come back to the CDC report. Next, I have on my list CMS, Mary Beth Hance.
Good afternoon. Thank you. And I apologize for not being able to be there in person today. I have just a couple of updates. First, I'm sure everyone is aware of this, but just wanted to mention it because it impacts so many of CMS's programs. And that is that the Inflation Reduction Act included immunization provisions for adult vaccine coverage and related costs to beneficiaries in Medicare, Medicaid, and the Children's Health Insurance Program. In Medicare, Part B generally covers commercially available vaccines, except for those covered under Part B. Starting in January 2023, Part D plans may not apply a deductible, coinsurance, or other enrollee cost-sharing requirement for Part D covered adult vaccines recommended by the ACIP. For Medicaid and CHIP, beginning in October 2023, coverage of ACIP recommended adult vaccines without cost sharing is mandated for enrollees who receive coverage under traditional Medicaid and for Medicaid medically needy enrollees in specified states, which I will not go into the nuances there. To CHIP enrollees who are 19 years of age or older. And our written statement provides a bit more of the details. We are currently assessing the guidance that we'll be putting out, but wanted to share this update. Also wanted to just mention that we have made updates to CMS.gov to provide updated seasonal flu vaccine information and pricing for the 2022 flu season. And we continue to amplify CDC and ACIP guidance regarding COVID vaccines. For example, we issued a press release on September 12th, highlighting that Medicare, Medicaid, and CHIP cover the bivalent boosters. Thank you very much.
Thank you very much. Next is DOD, Lamont Collins.
Yes. As of the 13th of September, DOD has administered over 8.6 million FDA-approved or authorized COVID-19 vaccines at approximately 400 sites globally to those individuals who are, based on age and medical history, have an indication to receive vaccine. Orders of bivalent COVID-19 vaccine booster dose are being received and vaccine administration has started. DOD will be conducting targeted outreach to those considered at high risk for severe disease from SARS-CoV-2. DOD is encouraging sites to administer influenza and appropriate COVID-19 vaccine if indicated at the same visit. In regards to monkeypox, DOD has received and is administering Jynneos vaccine for monkeypox prevention in accordance with CDC recommendation. ACAM 2000 is offered only in those who have previously received ACAM 2000 and elect to receive ACAM 2000 over Jynneos. And then finally, DOD has received about 80% of its influenza vaccine order and has been distributing to DOD sites statewide and overseas. Influenza vaccine is a requirement for service members and healthcare workers who don't have approved exemptions. And DOD is encouraging sites to administer influenza and appropriate COVID-19 vaccines at the same visit. And that's all. So thank you.
Thank you, sir. Next, FDA, Jay Slater.
Okay. Good afternoon, and I do apologize for just popping on. We have a competing advisory committee going on all day today that I had to attend, but happy to be here. This is the update from the FDA from the last meeting. And as you'll see, it's mostly dominated by issues having to do with COVID-19, but we did have some other activity as well. On the 3rd of June, the FDA approved Priorix for the prevention of measles, mumps, and rubella to individuals 12 months of age and older. Then on the 17th of June, the agency instituted an emergency use authorization for both the Moderna COVID-19 vaccine and the Pfizer-BioNTech COVID-19 vaccine for the prevention of COVID-19 to include children down to 6 months of age. On the same day, the 17th of June, FDA approved an additional indication for Vaxneuvance for the prevention of invasive disease caused by strep pneumoniae, serotypes 1, 3, 4, 5, 6A, 6B, 7F, 9V, 14, 18C, 19A, 19F, 22F, 23F, and 33F, this time for individuals 6 weeks through 17 years of age. In July of this year, the agency approved several influenza vaccines for the 2022-2023 influenza season, a total of 8 vaccines. On the 8th of July, Comirnaty was approved for individuals 12 through 15 years of age for the prevention of COVID-19. On the 13th of July, the Novavax COVID-19 vaccine was given an emergency use authorization for the prevention of COVID-19 in individuals 18 years of age and older. On August 9th, emergency use authorization was provided for Jynneos vaccine to allow healthcare workers to use the vaccine by intradermal injection in individuals 18 years of age and older who are determined to be at high risk for monkeypox infection. The EUA also allows the use of the vaccine in individuals younger than 18 years of age determined to be at high risk. But in these individuals, Jynneos is administered by the conventional subcutaneous injection route. On August 19th, emergency use authorization was provided for the Novavax COVID-19 vaccine adjuvanted for the prevention of COVID-19 in individuals 12 through 17 years of age. The agency had previously authorized the vaccine for individuals 18 years and older. And finally, on the 31st of August, the agency amended the EUAs for both the Moderna COVID-19 vaccine and the Pfizer-BioNTech COVID-19 vaccine to authorize bivalent formulations of the vaccines for use as a single booster at least 2 months following the primary or booster vaccination. The bivalent vaccines, which the agency will also refer to as, quote, updated boosters, contains 2 messenger RNA components for SARS-CoV-2 virus, one for the original strain and the other one in common between the BA4 and BA5 lineages of the Omicron variant. The Moderna COVID-19 vaccine bivalent is authorized for use as a single booster dose for individuals 18 years of age and older. The Pfizer-BioNTech COVID-19 vaccine bivalent is authorized for use as a single booster dose in individuals 12 years of age and older. And that completes my update to the meeting.
Thank you very much, Dr. Slater. Next, for HRSA, Roxana Deba.
Can you see me?
We see you, and you're loud and clear.
Thank you. I just wanted to, first of all, thank you, NVAC, for creating the hybrid option. It is a wonderful feat on your part, and thank you. And you might have seen Mary Rubin, a familiar face to you before, but she moved on, so I'm grateful to be here. I'll try to make this as brief as possible. I'm going to just briefly tell you about the Division of Injury Compensation Program activities at HRSA. To start off with, the National Vaccine Injury Compensation Program update, VICP, continues to process an increased number of claims. I know you're probably tired of hearing so many numbers, but in fiscal year 2021, petitioners filed over 2,000 claims with the VICP, and nearly $208 million was awarded to petitioners. And in addition, $36.5 million was awarded to pay attorney fees and costs. In fiscal year 2022, as of August 1st, petitioners filed 736 claims with the VICP, and approximately $157 million was awarded to both petitioners and including attorneys' fees and costs. As of August 8th, 2022, VICP had a backlog of about 1,500 claims alleging vaccine injury that were awaiting review, and there's always up-to-date information on the HRSA.gov vaccine compensation website. And just to give you a quick glimpse of what's happening on our countermeasure side, the countermeasures injury compensation program, as of July 1st, 2022, there's been 8,808 claims alleging injuries and deaths from COVID-19 countermeasures filed with the CICP program, including approximately 5,700 claims alleging injuries and deaths from COVID-19 vaccines. 31 claims have been denied compensation. One claim has been determined medically eligible for compensation. However, compensation has not been awarded yet. You can find more information on the HRSA.gov CICP website. Thank you.
Thank you very much, Ms. Diva. Next, Indian Health Services, Uzo Chukuma.
Hello, everyone. Good afternoon. Can you hear me?
You're loud and clear. I see your face.
Thank you. Thank you for the opportunity to participate in this NVAC meeting virtually. I am Uzo Chukuma, and I'll be presenting the update for the Indian Health Service. We submitted a written response, but I would like to share a few highlights with you. The Indian Health Service continues to confront the SARS-CoV-2 pandemic and its impact on the population health and routine vaccination efforts. Since September 2022, the IHS COVID-19 vaccine task force was prioritized equitable access, distribution, and administration of COVID-19 vaccine throughout Indian country. To date, participating federal and tribal urban facilities within the IHS jurisdiction have administered over 2.3 million COVID-19 vaccines. According to the CDC COVID tracker, among the estimated 2.1 million people served at IHS, about 34% of them have received the booster shots. In light of the EUA that was issued by the FDA for the COVID-19 bivalent booster, the IHS is actively engaged in distribution efforts of the bivalent booster vaccine for those who are 12 years old and older in Indian country. Meanwhile, the IHS continues to routinely collaborate with CDC and also engage tribal leaders to support vaccine confidence efforts amongst the American Indian and Alaskan Native population. You all know that August was National Immunization Awareness Month, and the IHS immunization program, in collaboration with the Vaccine Task Force, highlighted the importance of vaccination for people of all ages. The IHS Chief Medical Officer conducted an outreach roadshow with various media and community engagements during August, promoting immunization across the lifespan for all American Indian and Alaskan Natives. To complement this outreach, the IHS also generated and updated tools and resources promoting immunization, and these were distributed throughout the Indian country. Additionally, the IHS immunization program continues to push vaccination among adults through provider trainings and webinars, and also promote the expanded adult pneumococcal, zoster, and hepatitis B vaccines. Indian Health Service tribal and urban and Indian health programs provide influenza vaccine services to American Indian and Alaskan Natives. And the IHS is geared for ensuring that all those who are eligible to receive the influenza vaccine receive their vaccine co-administered with the bivalent boosters for those that are eligible. The IHS Vaccine Task Force infrastructure was additionally leveraged to ramp up the response to the monkeypox public health emergency. We are currently working closely with our partners at CDC and ASPR on the distribution and administration of monkeypox vaccine and other medical countermeasures in Indian country. Monkeypox vaccine administration reporting is on the way within IHS since the release of the reporting requirements. Additionally, the IHS is working towards an enterprise-wide solution for reporting the administration of the monkeypox vaccine. We continue to collaborate with CDC, ASPR, and SNS for future allocations of the monkeypox vaccine for the IHS. And we look forward to the continued collaboration with our tribal, urban, and federal partners to ensure access to safe and effective vaccines across the age spectrum for Indian Americans and Alaska Natives served by the Indian Health Service. And that concludes my update. Thank you.
Thank you very much. Is there a report from CDC? I've got Ram Kapaka on our list. All right. Not hearing that, we will move on. Roxana Deba, do you have an ACCD report, or was that included in your previous presentation?
No, I included it in the briefings. Thank you.
Had to give you a second shot. All right. Thank you.
Thank you.
Next, AHIP, Chris Riegel.
Thank you very much. As health insurance providers, we strive to ensure that all Americans have access to vaccines and preventive care that they need to avoid developing preventable diseases. Throughout the COVID pandemic, insurance providers have worked to provide equitable access to COVID-19 vaccines, and we will continue to promote the new formulations of the vaccine this fall. We will also continue to work with the administration and other stakeholders to ensure a smooth transition for when COVID vaccines and therapeutics will be available commercially rather than through government purchase. Beyond COVID-19, health insurance providers have continued their work to inform their members and provider networks about emerging vaccine preventable diseases, including monkeypox and polio, and to provide their members access to recommended vaccines. Insurance providers are also working with other stakeholders, including providers and community groups, to disseminate accurate information on vaccines, especially regarding the safety and efficacy. We continue to regularly disseminate resources and guidance to our members on key vaccine-related issues to ensure information they have is up-to-date and relevant. While we pay abundant attention to COVID-19 and other issues like monkeypox and polio, it is also important that we not lose sight of the importance of routine vaccinations. We continue to collaborate with providers to make vaccines accessible in equitable ways and have facilitated larger scale vaccination events, including mobile vaccination units and events that target specific communities, such as back-to-school events, to promote easy access. We recently published 2 new briefs that address routine vaccines. One is a short document on the value of childhood vaccines specifically, and then we have an issue brief describing what insurance providers are doing to ensure all of their members get recommended routine vaccines. The all ages vaccine brief is part of a new paper that we published that highlights how health insurance providers are improving access to preventive care broadly and doing what they can to encourage their members to get and stay up to date with recommended preventive services and screenings. Finally, we continue to work with NVAC, ACIP, and state and federal authorities to ensure that vaccines remain at the forefront of health in America and that every American has access to affordable vaccines that are recommended for their life situation.
Thank you, Chris. Next is AIM, Claire Hannon.
Thank you. I'm Claire Hannon from the Association of Immunization Managers. We recently held our Leadership in Action conference. It was great to have an in-person conference after so long. And all of the presentations and content from that conference are on our website. We held our awards, our annual awards during that conference, and I just wanted to shout out to NVAC member Molly Howell, the immunization program manager in North Dakota, who received the Natalie J. Smith Excellence in Program Management Award. Earlier in August, we collaborated with CDC to give out the Champions Awards, which recognizes individuals in states and localities who have been immunization champions. 28 awards were given out in 28 different jurisdictions. We have a new podcast called Aiming to Inform, and it features conversations with immunization program managers. Very interesting. You can access those on our website. And we recently conducted a webinar on translating vaccine confidence research into practice. And we featured 3 evidence-based models to increase vaccine confidence in communities. That was last week, and it's also, the recording is on our website. We have launched a member assistance program that is focusing on adult immunization and features business operations toolkit and other resources for public health immunization programs to staff adult immunization activities. And then I just wanted to comment that the program managers, of course, are very busy continuing to roll out the COVID Omicron booster, to conduct back to school activities, catch up on routine vaccines, and also involved in the monkeypox vaccine rollout. Thank you.
Thank you, Claire. Next is ARA, Rebecca Coyle.
Thank you and good afternoon. I'm Rebecca Coyle. I'm with the American Immunization Registry Association, and I just have a couple of updates for you. As Claire and others have noted, monkeypox is consuming a lot of activities in state and local health departments. I think, as was highlighted earlier today during the presentations and then also through the questions that were asked, there are a lot of challenges out there that exist with rolling this vaccine out using different systems that maybe weren't tested prior to this. So I'm confident that we're going to get to a point where things continue to work in the way that they need to, but there's still a lot of work to be done in the meantime. We have added a monkeypox response portion to our webpage just to include some links on the information for folks that are trying to use IIS or to retrieve information from various IISs that for any vaccine administration, where to go and how to retrieve those records. Some of the other pieces I think that we're very excited about are sort of moving into that next world where we're actually able to use our data to kind of better I think, look at the vaccines that have been in existence, how they impact long-term effects. And so we've partnered with, we're assisting with the Recover EHR IIS project. And this is really leveraging the PCORI network out there, of which probably many of you are familiar or maybe even are participating with. But it's really designed to evaluate IIS data in conjunction with individuals that had COVID and then determining what role vaccines have played in long COVID and other areas as well. So it's kind of exciting to actually see this in progress now. We're working with several jurisdictions now to work on that data exchange and are exploring several different options for that, some of which might be a direct connection already. Others are really looking at more of a batch or large query of the IIS. So we're excited for that. And then lastly, I'll just mention, as we continue to expand our measurement and improvement program, this is really a program that evaluates existing IIS systems out there and key components of that system, for example, clinical decision support. I'm pleased to say that our advisory work group just met earlier this summer and have decided to move forward with the Data at Rest project that we have. So this is looking at data that's already existing in a system to evaluate the quality of that data moving forward. We know data quality is a persistent issue and will never go away, but we're trying to do our best to start measuring and assessing that. So that is my report, and it is available in SharePoint for all of the members. Thank you.
Thank you, Rebecca. Next is American Pharmacists Association, Jean Good.
Hi, thanks, Bob. So we've uploaded a report in SharePoint as well. And just a reminder that the American Pharmacists Association is the largest pharmacy organization in the U.S., representing over 60,000 pharmacists, student pharmacists, and pharmacy technicians. And just like the immunization program managers, the pharmacists are also busy with COVID-19 vaccines, catching up adolescents and children with their routine vaccines, and now heading into influenza season. APHA still leads the profession with helping with engagement, training, and education, as well as information and resources. Just to highlight something that's relevant to today's meeting, APHA has a cooperative agreement with CDC to look at vaccine confidence and other stakeholders. They hold a monthly collaborative with pharmacists, student pharmacists, residents, and people on the front line to talk about vaccine confidence. And there's a website, vaccineconfidence.pharmacist.com, that if you're interested to look at that. The other issue is people have talked about monkeypox. APHA also has a new CE on demand to help with monkeypox administration, and especially intradermal. So it's free. You can upload and look at that. And then there's also a new article written by John Gravenstein about the pharmacist's role in COVID-19 pandemic that's available. And so those resources are in the written report. Thank you very much.
Thank you, Kelly. Next is ASTO Meredith Allen.
Hi, nice to be with you virtually today. Thanks for the opportunity. I wanted to draw your attention. We also have submitted a written report, but just to give you a few highlights, ASTO continues to support states as they're busy rolling out the bivalent booster, along with trying to increase vaccination rates for pediatric and adult COVID vaccinations. We've also developed several resources, including a recent brief on religious exemptions and state vaccination laws. Also around COVID, we have several editions or podcasts related to our Public Health Morning Review edition, some that are offering flu vaccine and COVID vaccine together, along with addressing some monkeypox inequities. We're also working on monkeypox, as sounds like everyone else is as well. We've developed a blog describing the legal considerations for scaling monkeypox vaccination efforts, and have also participated with many others around a request for increase in funding for the national monkeypox request. ASTO also works with the APHA, the American Pharmacists Association, to lead the National Association's Leadership Council on COVID-19 vaccination planning and campaign implementation. And this is really a great space for public health and pharmacy to work together around the rollout of these vaccines specifically for COVID. We also have work going on with some of our other projects, specifically around supporting data sharing and partnerships between state immunization information systems and health information exchanges. We're also doing work around reducing disparities, both racial and ethnic disparities in vaccination rates, and increasing knowledge and trust in vaccines, working with some community action groups. And then we also have been doing some public opinion polling, working with Harvard University, looking at 3 different public opinion polls this far this year that are really looking to give time-sensitive data from the public and their perspectives to be able to help tailor state public health messaging around trust in public health, changing COVID recommendations, and also the vaccinations. Thank you for the opportunity to give you the update.
Thank you, Meredith. Next is NACCHO John Douglas.
Yeah, good afternoon. Glad to be able to join remotely. Sorry I'm not there in person. In addition to the written report that was submitted, I had a couple of brief highlights. NACCHO remains operations in an incident command structure for COVID, as it has now for several years, as well as also now recently monkeypox. A major part of that effort is to support local health departments in situational awareness, information sharing, advocacy, and particularly helping local health departments with vaccine distribution. Of course, now that we're in the fall, that involves not only boosters for COVID, but very intensive efforts in monkeypox vaccine distribution. Relevant to the COVID issue, a second thing I wanted to highlight is a report NACCHO recently released on what it calls forces of change. And this is a survey that's conducted every 2 to 3 years. It's the first one that's occurred during the pandemic, really trying to outline the impact of COVID pandemic response on state and local health departments. Among the notable findings, really not a surprise, but it documented that 80% of local health departments had reassigned staff to respond to COVID, that financial and human resource capacities hindered the response, forced a suspension of many routine public health services, and probably in many jurisdictions, although data is still being collected, exacerbated health inequities. another impact of the pandemic that I think we're just beginning to understand. NHO remains active in other types of immunization. We held a national stakeholder consultation on influenza vaccination in older adults in July. And also in July, there was a workshop on vaccine hesitancy, an effort that NHO has been undertaking for the last several years. This includes a project that's also been going on for several years in about 20 local health departments called Equipping Local Health Departments to Address Vaccine Hesitancy. I think, by the way, the findings and recommendations in the report from this morning will be quite helpful to that whole effort. NHO remains involved, as already mentioned, in supporting local health departments for COVID vaccination efforts, specifically with a project called Supporting Local Health Departments to Increase Vaccine Uptake through the COVID-19 Project. There are efforts underway for broader adult vaccination efforts. Like Dr. Hopkins, I was impressed that we may be able to sell adult vaccines for more than infectious disease prevention if it really is related to neurologic disease prevention. A project called Partnering for Vaccine Equity aims to increase the local health department capacity to improve adult vaccine coverage by identifying and implementing strategies to reduce racial and ethnic disparities. And then finally, on the more positive side of the confidence hesitancy coin, NHO is expanding a project called Equipping Local Health Departments to Build COVID Vaccine Confidence, and has now recruited a new cohort of health departments to be learning communication strategies to more effectively deal with what I think we all would agree is a mounting problem. Thank you very much.
Thank you very much, John. And just to let the committee members know, there are reports from CDC and the Public Health Agency of Canada in the SharePoint for your review. This ends our federal agency and liaison representative reports for today. Thank all of the participant organizations and members for providing those updates. We're nearly reached the time of public comment. I understand we do not have a public comment on the line at this time. I do not see that we have anybody here in the room for public comment. So that said, I will call our meeting to close for the day. I want to thank all of you for participating in our National Vaccine Advisory Committee meeting today, September 22nd. Look forward to seeing those of you that are able to join us online and in person tomorrow, September 23rd at 9 o'clock in the morning Eastern Time. Thank you.
Produced by the U.S. Department of Health and Human Services.